Now I am going to explain to you in details about the histological diagram of neuroblastoma. If we take this particular nest of cell, this solid sheet of cell, as we can appreciate, this is a classical solid sheet of cell, and if you look at the individual cells, okay, they are small. Okay, the nucleus is round. They are dark hyperchromatic and blue in color. Okay, they have indistinct cell border. The cell border is not that much distinct, and they have very scanty cytoplasm. So this classical feature, these are all features indicative towards their primitive nature. That is, these are the neuroblastic cell. These are the neuroblast. Okay, very important. So these are the neuroblast, as we can appreciate in this particular diagram. If you look at this area, this background faint eosinophilic material, that is this background material, if you can see, this represents what is called as the neuropil, which is corresponding to the cell process or the neuritic process of these neuroblast. Okay, is it very clear? If you look at this other diagram, what we can see, all the features that we have already appreciated above. Okay, we can see abundant amount of neuropil, we can see the solid sheets of neuroblast, and we can see certain structures over here. Yes, what are these structures? Can anyone of you tell or guess? Yes, so these structures are nothing but these are the pseudo rosettes. Okay, and in case of neuroblastoma, we call it as the Homer right pseudo rosettes. As you can see, the center part is containing neuropil, that is basically surrounded by the tumor cells, as we can appreciate from these diagrams. So this center part you can see. Hello students, welcome back. Myself Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to resume our high yield topic number 7, and as you can understand, today's topic of discussion is neuroblastoma. Now, neuroblastoma is one of the very important adrenal medullary tumor, and it is one of the components of the small round blue cell tumors of childhood. So, the small round blue cell tumors of childhood comprises of neuroblastoma, Wilms tumor, lymphoma, rhabdomyosarcoma, Ewing sarcoma or peanut, medulloblastoma and retinoblastoma. So these are the very important components of the small round blue cell tumor of childhood. There is another small round blue cell tumor which affects especially the adults, that is the small cell carcinoma of the lung. Now neuroblastoma, if you see, just like the pheochromocytoma, it is also derived from the primordial neural crest cells, and these primordial neural crest cells, they are present not only in the adrenal medulla, but they are also present along the sympathetic chain. Okay, so neuroblastoma can arise not only from the adrenal medulla, but it can arise from anywhere along the sympathetic chain where there is presence of the neural crest cell. One very important MCQ, that neuroblastoma, it is the most common extracranial solid tumor of childhood and most frequently diagnosed infant malignancy. So it's a very important MCQ. The median age of diagnosis of neuroblastoma is around 18 months or 1.5 years. Now 40% cases, they are diagnosed in infancy. Now most of the cases, they are sporadic in nature, whereas only 1 to 2% of the cases are familial, and it occurs because of mutation in ALK gene. So familial neuroblastoma can occur because of mutation in several genes, but out of them the most common is the ALK gene. Other genes that can lead to familial neuroblastoma is FOX2B gene mutation as well. Even though there has been a lot of advances in the treatment of neuroblastoma, yet the 5-year survival rate is standing at only 40%. Now children with neuroblastoma aged less than 18 months, they have a much better prognosis. So age is very important, or age of diagnosis is very important in the prognostication of neuroblastoma. Now, the most common genetic alteration seen in neuroblastoma is gain of 17q, which is seen in 80% of the cases. Whereas the most important genetic alteration, it is the overexpression of NMYC oncogene, which is seen in 25% of the cases. And this is the one which has a bearing on the prognosis of neuroblastoma. The most common site of distant metastasis for a neuroblastoma, if you have to choose one, it is the lymph node, followed by the bones, bone marrow, liver. It also affects the lung, though it is involved rarely. Now, neuroblastoma can be associated with various syndromes like your Beckwith-Wiedemann syndrome, Hirschsprung's disease, Turner syndrome, neurofibromatosis type 1. Now, the most common clinical presentation of a neuroblastoma is that it presents as an abdominal mass, but it can have uncommon manifestations also. For example, it can present with watery diarrhea, Cushing's syndrome, heterochromia iridis. Now, this Cushing syndrome and heterochromia iridis occurs because of the involvement of the cervical sympathetic ganglia. It can also present with opsoclonus and myoclonus, which is basically an autoimmune process directed against the neural tissue, wherein the patient has classically dancing eyes and dancing feet. Now, clinically, there are two important presentations of neuroblastoma. One type presents called as the pepper type, another type called as the Hutchinson type. The pepper type basically presents in stillborn, and involves young infants characterized by massive liver metastasis, whereas the Hutchinson type involves the older age group and there is an extensive bony metastasis involving the skull and the orbits, and to the extent that it leads to exophthalmos as well. Now, despite these tumors elaborate catecholamines, hypertension is less frequent with these neoplasms if you compare it with pheochromocytoma. This is again a very important MCQ. Coming to the classification of the neuroblastic tumors, it becomes very important to understand that the neuroblastic tumors, it can be divided under three headings. Number one is the most primitive or undifferentiated form of neuroblastic tumor, that is your neuroblastoma. The second important thing is ganglioneuroblastoma, which is of intermediate maturation. The third is the most mature one, that is mature ganglioneuroma, which is the most mature. Remember, from now on, NB stands for the most primitive form of neuroblastoma, that is the neuroblastoma. GB stands for ganglioneuroblastoma and GN stands for ganglioneuroma. So this one is the most undifferentiated and this one, it is the most mature form. So if you look at the location of neuroblastoma, majority of the neuroblastoma, it arises basically from the adrenal medulla, that is 40% cases of childhood neuroblastoma is arising from the adrenal medulla, whereas rest of the cases, they might arise anywhere along the sympathetic chain, including the paravertebral region in 25% of the cases, posterior mediastinum in 15% of the cases, and other sites like the pelvis, neck and the brain might be involved as well. Now, one very important thing that you have to understand before I go further on, that basically in neuroblastoma you have certain types of cells ranging from the most primitive cell, which is very small, having a very high NC ratio and very little cytoplasm, to cells which are having excessive amount of cytoplasm. Okay, so these cells which are the most undifferentiated, they are called as the neuroblast, whereas the most mature cells which are derived from the neuroblast, they are called as the ganglion cell. So more is the amount of the ganglion cells, better will be the prognosis. So, and as you go from the neuroblastoma to ganglioneuroblastoma to mature ganglioneuroma, you are going to have more amount of ganglion cells. More will be clear later on in the later half of the lecture. Now, if you look at the morphology of neuroblastoma, so they can range from either very minute nodules, okay, to very large masses more than a kg. They are well circumscribed to widely infiltrative. The cut section is soft grayish tan tissue. Now, larger tumors can have areas of necrosis as well as hemorrhage. Occasionally, there can be areas of intratumoral calcification as well. So, this is the gross feature as we can appreciate for a neuroblastoma, as we can see in this diagram. This area, as you can appreciate, okay, this is pale. This area is quite pale, tan, grayish white in color, is grayish white in color, and as you can see, there are areas showing focal hemorrhage. So there are focal areas of hemorrhage as well. So this is how neuroblastoma present grossly in a 13-month-old boy. Now, microscopically, if you see these tumors, classically they are composed of a small primitive appearing cells with a dark nucleus, scant cytoplasm and poorly defined cell borders growing in solid sheets. That is why they earn the name small round blue cell tumor. Now, the background of the tumor will demonstrate a faintly eosinic fibrillary material called as the neuropil, which is nothing but the neuritic or the cell process of the primitive neuroblast. Typically, these tumors also contain a feature called as pseudorosettes. Okay, especially we have Homer-right pseudorosettes. Okay, wherein you will see that there is the occurrence of neuropil in the center, which is surrounded by the tumor cells, and this occurrence is called classically as the Homer-right pseudorosettes. Okay, they can be found in which the cells are concentrically arranged about a central space which is filled with neuropil. Okay, so this central space is filled with the neuropil, and around the neuropil we are having the tumor cells surrounding the neuropil. Okay, and this entire structure is called as the Homer-right pseudorosette, which I am going to demonstrate you as well. So as I was already telling you before, so as you are going to go from the neuroblastoma to ganglioneuroblastoma to ganglioneuroma, okay, you are going to see certain things. Okay, so as you are moving from the neuroblastic tumor to the ganglioneuroma, remember this part is the most immature form. This part is the most mature form of the tumor, and the central part, the intermediate part, is a mixture of two. It contains cells with variable maturation. So what we are going to witness that as you move from the neuroblastoma towards the ganglioneuroma, the amount of maturing ganglion cells are going to increase. What are these ganglion cells? These are very large cells with abundant cytoplasm. They have large vesicular nucleus containing a very prominent nucleoli. These are the ganglion cells. Okay, so as you are going to go from neuroblastoma towards ganglioneuro and ganglioneuroma, you are going to see an abundance of these ganglion cells. Okay, now the second thing is the amount of this neuroblast, that is the most primitive cell, that is going to decrease as you move from the neuroblast to the ganglioneuroma. So there will be a decrease in the amount of the primitive neuroblast, and as you go from the neuroblast towards the ganglioneuroma, there will be appearance of the Schwannian stroma. The presence of Schwannian stroma, it is indicative of a favorable prognosis, and not only that, the presence of all these three factors favors a good prognosis histologically. So I hope you have understood. Now I am going to explain to you in details about the histological diagram of neuroblastoma. If we take this particular nest of cell, this solid sheet of cell, as we can appreciate, this is a classical solid sheet of cell. And if you look at the individual cells, okay, they are small. Okay, the nucleus is round. They are dark hyperchromatic and blue in color. Okay, they have indistinct cell border. The cell border is not that much distinct, and they have very scanty cytoplasm. So this classical feature, these are all features indicative towards their primitive nature. That is, these are the neuroblastic cell. These are the neuroblast. Okay, very important. So these are the neuroblast, as we can appreciate in this particular diagram. If you look at this area, this background faint eosinophilic material, that is this background material, if you can see, this represents what is called as the neuropil, which is corresponding to the cell process or the neuritic process of these neuroblasts. Okay, is it very clear? Okay. If you look at this other diagram, what we can see, all the features that we have already appreciated above. Okay, we can see abundant amount of neuropil, we can see the solid sheets of neuroblast, and we can see certain structures over here. Yes, what are these structures? Can anyone of you tell or guess? Yes, so these structures are nothing but these are the pseudo rosettes. These are the pseudo rosettes. Okay, And in case of neuroblastoma, we call it as the Homer right pseudorosettes. As you can see, the center part is containing neuropil that is basically surrounded by the tumor cells, as we can appreciate from these diagrams. So this center part, you can see the center part over here is the neuropil, and surrounding, if you can see, these are the tumor cells. Okay, this is classically called as the Homerite pseudorosette. Okay. Sometimes you will see intratumoral calcification is also present, and if present, it is associated with again a good prognosis. Now this is another diagram which is a high power view over here, that we can appreciate the individual neuroblast. But over here the neuroblasts are quite undifferentiated, wherein some of them contains prominent nucleoli. And the presence of such features of neuroblast correspond to the MIC-N amplification. So MIC amplified neuroblastoma contains undifferentiated neuroblast, very primitive form of neuroblast, which are pleomorphic and they are containing prominent nucleoli. Okay. Now here we see what is called as a ganglioneuroblastoma, where we see there is a mixture of the neuroblastic cells, as we can appreciate over here. So some small primitive bluish neuroblastic cells are there. Along with that, what we see that there are certain mature ganglion cells. So these large cells, as you can see over here, these are the mature ganglion cells at varying stages of maturation. Okay, there are ganglion cells at varying stages of maturation admixed with the neuroblast, So the neuroblast have started differentiating in towards the ganglion cell. So such a mixture of neuroblast along with the ganglion cell is called as the ganglioneuroblastoma. Coming to the next diagram, if you will appreciate over here this next diagram. Now this diagram is also that of a ganglioneuroblastoma, wherein you have a mixture of the neuroblastic cells, as you can see, and you can see the ganglion cells also over here. You can appreciate the ganglion cells over here. But very important thing is, as the maturation is taking place, you can see the presence of Schwannian stroma. Okay, this the Schwann cells are cells which have a spindle-shaped buckled nucleus. Okay, that is the classical appearance of a Schwann cell. So the appearance of Schwannian stroma is very important, and this indicates a good prognosis. Okay, let's go ahead. This is another diagram over here. This is the classical diagram of a ganglioneuroma. This is the most mature form of a neuroblastic tumor, wherein you will not see any primitive neuroblast. Just you are going to appreciate the mature neoplastic ganglion cells, and you can see the classical spindle-shaped Schwannian stroma cells, which a buckled nucleus, as I have already shown you previously. So this is all about your ganglioneuroma. So we have discussed in detail the histological features of neuroblastoma. We have seen ganglioneuroblastoma, and we have also seen the ganglioneuroma. Now very important from the exam point of view is the staging of neuroblastoma. So if you see over here, there are basically 4 important stages, with the stage 2 having 2A and 2B, whereas the stage 4 has a variant with a good prognosis, that is 4S. Typically remember, stage 1, 2 and 4S, they are good stages. Okay, so they have a good prognosis, whereas the stage 3 and 4, they have a bad prognosis. But unfortunately, one thing, if you are going to see, around 60 to 80% of the children, they present with stage 3 or 4 tumor. So majority of them are presenting at a later stage, which is very unfortunate event. And around 20 to 40% of the cases only will present with stage 1, 2, 2A and 4S, which is having a good prognosis. So we have to understand very importantly what are the different stages. So the staging is given by the International Neuroblastoma Staging System, that is the INSS system. So stage 1 tumor is that which can be completely removed, and the same sided lymph nodes, they are negative for the tumor. Stage 2 tumor is when the tumor is localized and can be resected incompletely grossly. So from the eyes you can make out that some part of tumor has not been removed. Plus over here the same sided lymph nodes, they are negative for the tumor. The stage 2B, again there is a localized tumor, whether it may or may not be completely removed. Okay, but the same sided lymph node, if you see, they become positive for the tumor, but the contralateral or the opposite side lymph nodes are negative for the tumor. Stage 3 is an unresectable unilateral tumor which has crossed the midline. Either this has happened with or without lymph node involvement, or the tumor is localized only but the opposite sided lymph node has been involved. That becomes stage 3. Okay, that becomes stage 3. So anywhere if the tumor is unlocalized, if it is unresectable, then it becomes stage 3, or if it is localized with contralateral lymph node involvement, then it is also stage 3. Any primary tumor with dissemination to the distant lymph nodes, bone, bone marrow, liver, skin and or any other organ except that is defined for the stage 4S, it is called as stage 4. So we have to understand what is stage 4S. Stage 4S, it is a localized primary tumor as we have seen in stage 1, 2 or 2B, where the dissemination is limited to either the skin, liver and or the bone marrow. Now remember, in the bone marrow, it means that the neuroblast should constitute less than 10% of all the nucleated cells of the bone marrow. If the neuroblasts are constituting more than 10% of the cells, then the stage is going to go up from 4S to stage number 4. Okay, the stage 4S is limited to infants who are younger than 1 year of age. So this is all about the staging system of the neuroblastoma. Now one very important factor over here is that multiple cutaneous, sometimes the child is going to present with multiple skin or cutaneous metastasis showing deep blue skin discoloration, and it gives an appearance of what is called as a blueberry muffin baby, unfortunately. Okay, this is also can be asked as an important MCQ. The most important thing that we have to understand in case of neuroblastoma is the prognosis. So there are many factors that can decide the prognosis of neuroblastoma. So first important thing over here is the stage. So as I have already said, the stage 1, 2, 2A and 2B, 4S, they are the good, they are showing favorable prognosis, whereas the stage 3 and 4, they show unfavorable prognosis. The age of diagnosis less than 18 months is a good prognosis, more than 80 months is a bad prognosis. If you look at the histology, the evidence of Schwannian stroma and gangliocytic differentiation is good prognosis, whereas the absence is the bad prognosis. The MKI index, that is the mitosis karyorrhexis index, less than 200 per 5000 cell is a good prognosis, more than 200 per 5000 cells is a bad prognosis. The DNA ploidy, if we see, hyperdiploid is a good prognosis, whereas near diploid is a bad prognosis. MIC amplification, okay, if it is there, it is a bad prognosis. Okay, if it is not there, it is a good prognosis. Okay, now chromosome 1p loss, if it is absent, it is a good prognosis. Okay, if it is present, it is a bad prognosis. Now one very important thing you have to understand, that chromosome 1p loss is strongly associated with the presence of MIC amplification. So they go hand in hand together. Again, the chromosome 11q loss is absent. If absent, it is a favorable prognosis. If present, it is a bad prognosis. TRK expression, if present, is a good prognosis. Okay, if absent, it is a bad prognosis. TRKB expression, if absent, is a good prognosis, is present if it is a bad prognosis. Now mutations in neuratogenesis gene, if it is absent, it is a good prognosis, if present, it is a bad prognosis. Now excessive amount of serum LDH levels along with rise in the serum ferritin levels, again they are unfavorable. Again they are unfavorable. Now if you look at the diagnosis of neuroblastoma, it is very easy. So clinically you can make the diagnosis according to the clinical features. You can go for the histopathological examination, the biopsy of the patients, or you can go for the lab diagnosis. Under the lab diagnosis, you can diagnose the presence of catecholamines as well as its metabolites in urine, mainly the homovanyl mandelic acid and the vinyl mandelic acid. Now immunohistochemistry, if you can do, neuroblastoma is positive for NSE, chromogranin, synaptophysin and NB84. NSE stands for neuron specific enolase. One of the newest markers that has been discovered is the FOXB2, which is now the most sensitive and the specific marker of neuroblastoma. So with this, we have completed the neuroblastoma in detail, and I hope you all have enjoyed this lecture thoroughly. Thank you very much for watching this particular video.